Good afternoon, everyone. This is Emily Clark. I am a knowledge broker for the NCCMT, and I'll be your host for today's peer-to-peer webinar brought to you by the National Collaborating Center for Methods and Tools. Thank you so much to those who have joined us for the webinar today. We'll quickly go over a few housekeeping items before we get started. Please see the chat section on the bottom right-hand side of the screen in WebEx. You can use this chat section to post any questions or comments that you might have during the webinar. We will have a designated Q&A session at the end of each presentation, but please feel free to post any questions or comments you have during the webinar. When you post in the chat section, please post your comments to all participants, as other participants may have the same questions as well. Today, we recommend using a wired internet connection as opposed to a wireless one. And if you do have any connection issues today, you can either send a message to Vivian Chen, who is on the line as well, who can help you with any technical issues you have, or you can call the WebEx 24/7 helpline, which is posted on the slide, and we will also post it in the chat section. After today's webinar, the presentation slides and video recording will be made available through the NCCMT's website. The link to this page will be posted in the chat section now. And that's great, so we'll move on to our first polling question today. We just want to get a sense of the audience that's joining us. We're wondering how many people are watching today's session with you. So please indicate if it's just yourself, if there are 2 to 3 of you, 4 to 6, 6 to 10, or if you are in a larger group as well. You can answer this question in the poll question panel on the side of WebEx, and just make sure that you hit submit so that it records your answer. So today it looks like we actually have a couple of larger groups, which is great, a couple of groups in the 6 to 10 range, and a number of people in smaller groups and joining by themselves, so that's wonderful. Thank you so much for joining us. I would like to officially welcome everybody to the inaugural webinar for the peer-to-peer webinar series. This is a new webinar series from the National Collaborating Center for Methods and Tools, and we've designed this to help share some of the success stories that exist in Canada around evidence use in public health. And we do want to just show that evidence-informed decision-making is achievable in public health in Canada, and these are some of the ways that people have achieved it. For those of you who may be unfamiliar with the NCCMT, we're actually one of 6 national collaborating centers across Canada. We're all funded by the Public Health Agency of Canada. We here at the NCCMT are located at McMaster University in Hamilton, Ontario, and the other NCCs are spread out from coast to coast. While the other NCCs focus on the use of research evidence in specific public health content areas, we focus on improving the access to and use of methods and tools for health professionals in practice in all areas of public health. So we're not content specific, but we focus on resources that can be applied across all different areas of public health. At NCCMT, we offer a number of products and services through the website. For example, the Registry of Methods and Tools is a database of resources to support knowledge translation in public health. Online learning opportunities include our learning modules, a core competency tool that links resources to the core competencies for public health, as well as a rapid review guidebook that details the steps for conducting a rapid literature review, as well as other online learning opportunities. We also offer in-person workshops on demand, which are great opportunities to build capacity in your department or your organization. Public Health Plus is a collection of quality appraised studies and reviews relevant to public health specifically. Our video series include the Understanding Research Evidence series, which explains statistical concepts in easy-to-understand 5 to 10-minute videos. And finally, we also engage in networking and outreach to help promote evidence-informed decision-making across the country. Today's webinar will feature stories from our newly launched Evidence-Informed Decision-Making Casebook. This casebook features 9 success stories of evidence use in public health in a variety of settings and contexts across Canada. The casebook is available at the link posted in the chat section, and I encourage you all to check it out if you haven't already. So without further ado, I'm very happy to introduce our first set of presenters today. It's my pleasure to introduce Debbie McNeil, a Scientific Director for Alberta Health Services, as well as Richard Musto, the former Medical Officer of Health for the Calgary Zone in Alberta. Thank you so much for joining us today, and I will pass it over to you.
Thank you, and we really appreciate this invitation to participate and share our story with you, and we look forward to the discussion afterwards. Can I just check that you can hear me well enough?
You sound great.
Okay, wonderful. So we're going to talk about the power of data and advocacy, changing school jurisdiction policies for human papillomavirus immunization. As you likely know, the human papillomavirus HPV vaccine prevents two types of HPV that cause roughly 70% of all cases of cervical cancer and 90% of genital warts. And it was introduced to schools in Alberta in 2008, beginning for girls in grade 5 and then next year to girls in grade 9. As we were preparing for the introduction of the vaccine, we thought we were going to be able to offer it everywhere, but in about June or July of that year, the Bishops of Alberta's Committee on Education issued their opinion on the vaccine and essentially asked the school boards to not permit in-school administration. Most school boards chose to ignore that direction, including Edmonton, Red Deer, Grand Prairie. But a couple, two or three, including Calgary and Medicine Hat, decided that they would follow that directive and not permit the in-school vaccination. We met with the bishop, who stated his concerns of vaccine safety and that to give the vaccine would seem to be encouraging sexual activity. He was sympathetic to the possibility of inequitable access, but wanted evidence. The superintendent personally was supportive, but did not want to be offside with the bishop, and so did not allow us to introduce the vaccine.
So we were in a situation where we were delivering the vaccine either in schools or in the community. And as Richard said, we were also thinking about this whole idea of inequity that was created from these differential delivery approaches. And, you know, one of the goals in public health is to reduce inequities. And so our public health research department had available data, and so we decided to try and identify if there was indeed inequity in vaccination access to see if that would help improve our chances of making some changes to the policy. So the objectives were pretty simple. It was to identify if there was inequity, and then if it was identified, to use that data to advocate for a change in school district policy to allow immunization in schools. So when we were thinking about this, I think social justice is sort of the central of what we were doing to try and use that as convincing information. But the whole thing was really an integrated KT strategy where public health officials and our research department really worked together. So Richard was intimately involved in all of the aspects of the study, and then we had a number of analysts who were doing the data analysis. And a lot of the work that we did was trying to figure out the best way to frame the messages once we had analyzed the data. I'm not going to talk too much about the study, but I want to give you enough background on it so that it makes sense. But I'll allow Richard lots of time at the end to talk about the advocacy work that was done. So the study actually has been published. It was published in 2012. And so there's lots of details on our methods and the results. But just to sort of give you a quick overview, we viewed it as a natural experiment. So we had a great public health immunization database, and we had data for grade 5 students girls from 2008 to 2011, and then grade 9 from 2009 to 2011. So we ended up with over 36,000 potential available data. And there was good information that was really helpful so that we could do a statistical modeling in our approach to the analysis and move beyond just description. So we had postal code, school type, whether it was public, Catholic, or private, the delivery system, whether they were delivering the immunization in school or in the community, their hepatitis B vaccination status, because we know that if you have hepatitis B immunization, you're more likely to be have HPV immunization, and then the number of HPV doses received, and we considered 3 doses as complete. The other thing that we did was link socioeconomic data to our immunization database. We didn't have individual information, so we used the girls' postal code, and then we linked it to something called the Pamphylon Deprivation Index. Most of you, I bet, are probably aware of it, developed in Quebec. We have it available for Alberta, so we have Alberta-specific data. We use Stats Canada data. We only use the Material Deprivation Index, which was income, education, and employment, and then we ended up assigning either high, mid, or low socioeconomic status after we did all of the linking. I can answer more questions about it as we move on after, just to let you know what we used for our equity factor. And then when we did the analysis, we examined the odds of being vaccinated for each of the vaccine delivery methods. We used multivariable logistic regression modeling, and anything that was 2 doses or less was considered incomplete, and 3 doses was considered complete vaccination. The predictors we were interested in were the delivery system, the school type, and socioeconomic status. And then we also incorporated grade, which took into account age of the girls and Hep B status. In the end, one of the things that we did was invite a biostatistician to give us advice. So this was a real expert who we worked with in the past in the analysis to make sure that we were really taking into account all the things that were important. And in the end, we ended up having 5 levels. So there were in-school vaccination, public schools, and then there were some Catholic schools, part of the French system, that were governed under the Edmonton Bishop and the Edmonton Catholic School Board, not very many in that system, and then private schools, and you can see those numbers are pretty small, and then in community, which were the Catholic school jurisdiction, and then the private schools that did not allow the nurses in to immunize. So when we looked at the results, interestingly and not surprisingly, for in-school, the completion rate was around 75% for the in-school program and only 36% in the community program. And when we did the modeling, what it essentially told us that was a girl attending a school with vaccinations on site was 5 times more likely to receive HPV vaccine than a girl with a community vaccine program. Now this next picture is from the article that we published, and you'll see from this the reduced immunization in the Catholic community immunization site compared to the public, and you'll also see the private in-school and the private community. So it didn't matter where. If you had in-school immunization, you were more likely to be immunized, and if you were lower socioeconomic status in the Catholic school system, you were even less likely to be immunized than if you were high socioeconomic status. And if you look at the red line on the public school, you'll see if you were low socioeconomic status, you were actually a bit more likely to be immunized. I'm going to turn it over to Richard now.
By the time we had these results, the campaign of other advocacy groups was very much in full swing, with unfortunately quite pointed and personal attacks on the bishop by both a university-led group and an aligned public community group, as well as strenuous advocacy focused on the board by a group of mostly retired senior educators, although that was behind the scenes. We felt it was very important for us to maintain healthy relationships, and so we made a point of placing the evidence front and center to our advocacy efforts. and avoided really any of the inflamed rhetoric that was going on. Because the bishop was key, he was the first person we presented to. He was impressed by the difference, but still did not indicate that he would change his position. We then presented internally to our public health teams, both locally and across the province, because, as I mentioned earlier, there were some other cities that were in a similar situation with their Catholic school boards. And we shared the results with both the university and the retired educators group, which led to the information being released into the public domain and then subsequent media attention. And we also posted the information on our website. There was a new superintendent, and again, he was sympathetic but still did not want to go against the bishop. However, the bishop encouraged the board to poll their parent councils and to share our information about the vaccine and the study with the parent councils. Finally, a presentation was made to the board itself, after which meeting the decision was to be made. This whole kind of iterative process of our dissemination strategy, and I must confess, we didn't think it all out as well as we might have at the beginning, but we adjusted as it went along and we perceived the needs of the audience. Our first reporting used odds ratios and a graphic of people to demonstrate the increased odds of not being immunized. But in the end, for the more lay audience, we used simple bar graphs to demonstrate differences in vaccine uptake. For the publication, we used profile plots based on the regression models that incorporated covariates to increase the scientific rigor of the study results. So here's the impact. As Deb had said, we wanted to judge the success of the strategy by whether or not we achieved our objective to change policy while maintaining these positive relationships and engagement with religious and jurisdiction officials and parents. The policy was changed in 2012, and there is now in-school immunization in both the public and Catholic school jurisdictions. You can see that before the study, this is a graph that Deb had presented, we had 75% uptake, full uptake in-school administration and 25% without. And 64% of only incomplete or unvaccinated girls, but a fair number of those were incomplete, which indicated the intent and suggested the barrier. After the change, we see that, in fact, the uptake is exactly the same between the public system and the Catholic system. So clearly this study was an important influence, as was the influence of the other lobby groups. We haven't done a subsequent analysis with the socioeconomic status, which hopefully we'll do, but we would expect to see that difference was eliminated as well. So in terms of lessons learned, first of all, it's important to identify who the participants are in the advocacy efforts and what their perspectives are. There were at least 4 groups advocating for inclusion in school, so a community group, an academic group, retired educators, and us within Alberta Health Services, and at least 3 against, bishops, a Catholic ethicist, and also a pair of academics who weighed in from the University of British Columbia. Not all were known to each other or the public. One thing I hadn't anticipated and learned, so it was a lesson for me, and I've tried to incorporate it in subsequent work, is to expect and be prepared for the personalization of the issue. At least one of the decision makers had a history of cervical cancer, and she felt that we were casting aspersions, if you will, about her moral character, that she or her husband must have had other partners. And I wasn't quick enough on my feet at that time to point out that the vaccine doesn't prevent all cancers, and so I left. She felt, I know after that meeting, that well, didn't feel good about the whole thing. And we also know that some of the other advocates had clear historical issues with the church authority, and that, unfortunately, I think, colored the kind of criticism that they made of the bishop. We learned that it was important to make expectations explicit in any collaboration. We were very liberal in the sharing of our data, but then felt badly about how it was used in some ways to, again, torque the message so that it was much more confrontational rather than a collaborative kind of piece. But we also learned by that, and without, I think it was in a subsequent advocacy effort where we had the research led by an academic at the university who was unable or unwilling to let us use the data in our advocacy until it had been published, whereas the publication for us was secondary.
Yes.
And I think this emphasizes the importance of having in-house capacity to do good quality research that addresses our important public health issues. Finally, it's clear that we're in it in public health for the long run. And so relationships for us are extremely important, and we must behave in a way that builds on those relationships, respectful of them. And in fact, it's our history of those relationships that will influence how the work goes. We were approached because of previous relationships that either I had or the previous medical officer of health had for assistance and to collaborate. And in fact, even the bishop came to me for an opinion on the quality of the evidence that the academics from the University of British Columbia were bringing. So even though we were lobbying to have the bishop change his position, he respected our relationship enough and our authority to ask for our input. I think that's really all we wanted to say about that. And Deb, did you want to add anything more before we open it for questions?
Yeah, just one thing. I didn't put in the data from the grade 9 students, but the immunization rates were virtually identical again, and it was up to 86% by grade 9, just for 2017 data.
Yeah.
Add that.
So we're happy to take any questions. Oh, I should acknowledge,
to acknowledge all the people that were involved with the study, and the Zone Public Health people who are great at helping us to clean the data and understand their data, and then all the analysis that happened.
Yep.
Thanks, everyone.
Great, thank you so much. So we will open it for questions now. In order to post a question, you can post it in the chat section in the bottom right-hand side of the screen. We will have questions now, and we'll open it up again to Deb and Richard at the end as well, in case you have any other questions that come up. I want to thank you guys for that presentation. That was a really excellent overview and really an inspiring story, and amazing to see the impact now in 2017 with the immunization rates. While people might be typing their questions, a question that I thought of was there any resistance, or did you have to work at all to get the views of the parents by any chance? I'm wondering, they seemed like a group that might have been considered stakeholders in this. Was there any resistance from the school's parents?
Well, we didn't have a direct relationship with them, except through our public health nurses that were delivering other vaccines in the schools. And their sense was that many parents wanted their girls vaccinated. And I think that they were making their views known to the board and to the bishop, and I think that was part of the rationale for the bishop making that suggestion so that he could really let the voice of the parents be heard. And it was very, very clear. Every single one of the parent councils indicated that they wanted the in-school vaccination.
And I think providing the information to the parent councils and the parents who wanted it, I think was really an important piece of it, so that it was coming from the grassroots too.
Yeah, and it was presented, both views were shared with the parent councils, and both views were posted on the Calgary Catholic Board's website.
That's great. Great. I also thought it was really interesting that you found it more effective to post or to share with lay people instead of an odds ratio, just a bar graph. I think that makes a lot of sense. It's a lot easier, I think, for people who don't work in the field to really understand that. So
yeah. That's
really fantastic. Great. So we will, I don't see any questions coming in right now. Again, feel free to post any questions as they come up. We will move on, I think. We're a little bit ahead of schedule, which is not a bad thing. But what we'll do then is move on to the next presentation. I'm very, very happy to introduce Victoria Cole, who is a Program Planning Management Officer for Ottawa Public Health. She will be presenting her story on an EIDM wiki at Ottawa Public Health, and I will pass it over to Victoria now.
Perfect, thank you. Thank you, Emily and Vivian, for having me. So before I start, I do want to acknowledge and thank our off-site librarian, Jane Beeler, just for helping with this initiative and being very supportive of EIDM at Ottawa Public Health. So for my presentation, I want to share my experience in creating a wiki to facilitate knowledge exchange at Ottawa Public Health, and I want to provide you with some organizational context of how we gather research evidence at Ottawa Public Health, and talk a bit more about the initiative and some of the challenges that I encountered along the way, as well as successes, and lastly, provide you with some lessons learned or recommendations. So if there's anyone out there that want to engage in something similar, they have something to work from. So setting the stage, so I want to give you a bit of context of what it's like at Ottawa Public Health. So we're a fairly large organization. At the time when the call of abstract for this casebook was open, there was approximately 500 staff, and we were divided in between 6 different branches. And everyone's often focused on meeting the needs of their clients, you know, whether it be internal or external clients. And how we're divided is that we often work in different topics or age groups as well. So it could be mental health or prenatal or seniors health as well. So as you can see, because of the way the organization is structured, there could be limited sharing of research evidence between the 2 teams, between any teams. And I think this is inherent not just within Ottawa Public Health, but any type of large organization. Knowledge exchange is always a bit more difficult. So in terms of how this issue kind of came to be that led to the development of this wiki was that I work more at a departmental level, so working with one-on-one teams in terms of consulting with them and how to gather research evidence. So I have the luxury of kind of seeing how things work. So I did notice while working one-on-one that there's some consistency in terms of how people view research evidence and even what people consider as evidence in general. So because there's all these lack of exchanges, there may be duplication that may occur in terms of people doing similar reviews, but just there's no communication between the 2 teams. So how the issue was actually identified was actually I was having a conversation with our librarian, and she kind of pointed out to me that, oh, I think someone else from Ottawa Public Health is doing something similar to what you're doing. So then that kind of got me thinking, well, why isn't there some of that knowledge sharing within our organization? So I do want to show you, this is kind of a flow chart to give you an idea of how we collect research evidence at Ottawa Public Health. And I will be making reference to this flowchart again at a later slide that will kind of show you how having this research evidence wiki has reduced some of the steps. So the rectangles, the blue rectangles, are the roles or actions taken by the staff member at Ottawa Public Health, and the purple oval, those are actions that will be taken by our off-site librarian. And the black bidirectional arrows indicate kind of the back and forth conversations that we have with the librarian and the staff. So I'll just quickly go through the flow chart. The first yellow starburst, so that's kind of when you identify an issue, and that can come from a variety of people. It may be from the staff member because it's something that they're doing in the community that they've noticed that there's a gap and they want to seek out some research evidence for that issue, or it can come from management, or perhaps there's a funding opportunity there. And then after that, once the issue is identified, there's a development of the research question. That's often done by the staff, and then the staff will then connect with our off-site librarian in terms of development of a protocol. She tends to do that, but there can be some back and forth with our staff member, and then the librarian will conduct the search, and then I'll go back to the staff who will review all the abstracts that she's found based on the search, and then a staff member will select the articles that they want to read, and then because we have limited access to full text articles, so the librarian often will give us links, or she'll purelate full text articles to the staff member, and then it's the staff's responsibility to read and synthesize the articles appropriately to get what they need to answer their research question. So some of the objectives that I have for this initiative, so the short-term objectives was really to provide a place for knowledge exchange. Like I mentioned in the previous slides, we're a fairly large organization, so we're often working within our teams, but there's limited dialogue between the teams. Another one was that I really want to create a centralized platform for staff to locate, where they could locate all the resources and kind of learn how to seek research evidence on their own. Another one was implement a consistent approach to retrieving research evidence. And I talked a bit about that in the last and previous slide already. There's a bit of inconsistency within the organization. And then I did want to streamline processes to avoid any type of duplication in terms of gathering research evidence, and hopefully that will be using less resources because there will be more collaboration. And the long-term objective was really to increase staff confidence so that they could learn how to gather research evidence and then appraise, and then hopefully in the long run is really using all this to incorporate that evidence into their public health practice or the decisions that they make. And the other one is really the other long-term objective was to really familiarize the staff, the organization with NCCMT's evidence-informed decision-making model, so utilizing the other different domains of evidence like community and political preferences and public health resources. So this is actually a screenshot of one of the pages of the wiki. So as you can see, it's quite simple. There's just it's just a table, and there's 4 columns. So if a staff member came to this wiki page, they could click on that research question, and then it'll jump to the actual document. So they can see what date's completed, what type of data is posted, and who it was completed by. So they can also have the option of actually just contacting that person if they want to know, seek out either get full text article to a specific article, or to view their research protocol. So the next page is actually, this is also a screenshot of another page on the wiki, and so this page was actually created as kind of like the home page for the research, the evidence from research. And the thinking process that led to the creation or development of this page was that initially the previous slide was actually the only page of the wiki, and because that allowed for other people to see what other people are doing. However, after I created that table, I kind of thought to myself, well, if someone that doesn't know how to actually go out and get research evidence, they can't really contribute to that page at all. So this page, Jane actually helped a lot with this. Jane's our offsite librarian, and this page is meant to, it's addressing that capacity building piece. So if they wanted to they didn't know how to define research questions, if they click on this hyperlink here, that's how they would be able to, look at some frameworks, like a PICO framework or a SPIDER framework. And then the last point, number 5, that's actually where the red oval and circles. If they clicked on that, that will take them to the previous page. So those are where all the previous literature reviews that have been posted by previous staff have been posted. And this is actually kind of like the newest addition to the wiki. So this is the evidence-informed decision-making homepage. You might recognize that the NCCMT's EIDM model is below. So, so this is really, it's kind of like the parent page, and the idea is really to embrace and try to get other people familiar with this model so that we'd be able to use it within our organization. So if you see on the right side that the red circle there, that actually takes you to the research evidence wiki page. So that's the previous slide that I just spoke about. So I think the long-term plan for this page is really that each of these domains will be hyperlinked, and a staff member would be able to click on that, and it'll take them to kind of like a resource page, or perhaps there may be a knowledge exchange opportunity for us, similar to the Lit Review posting page, where they could see the tools or connect with other people that are working on something similar to them. So in terms of the development of the initiative, there's kind of 4 phases. So the first part was really the content development. So as you can see, we based a lot of the staff that we have from NCCMT. So in terms of trying to figure out what content we wanted to put on the wiki, it was done in collaboration with our offsite librarian. And the reason for this is we wanted to ensure there was a consistency between what was on the wiki and what resources staff are accessing, and what she's when she's working with staff one-on-one or at her on-site workshops. We wanted to make sure that it was we were both directing people to the same resources as well. The other content on the wiki were the templates that we use for synthesizing evidence. So this was developed in-house in consultation with our specialists at Ottawa Public Health. And lastly, the other type of content, which is probably the most important content, are the actual reviews that people complete. So initially, I had to go around kind of asking people, have you completed a review recently? Can I post your results on there? So I'll speak to that a bit more, because that was one of the challenges I encountered as I was developing this wiki. So the second phase is really software selection and construction. So I worked together with our internal information technology staff here, and the wiki platform was chosen because of its accessibility and its collaborative functions, which really allowed for people to kind of post their own reviews, their own completed work with very limited training or instructions. And there are additional features for the wiki, such as the ability to do any keyword search, or you can sign up for email notification if there's a new review that was posted, and just the ability to organize information in general. So those are some differences that you might not get if you wanted, instead of just posting everything on a shared drive, which you could do, but you might not have some of those features. So the last part was really about implementing and promoting an awareness. So this wiki was implemented in June 2016, and really it was just going to, once everything was up, I just went to all the team over the summer and did a little demo and talked to them a bit about the evidence-informed decision-making model, and had to show, and I did put up some of the synthesis, the completed synthesis, kind of I use that as an incentive for them to go to it so they can kind of start and see what other people are working on. And then the promotion and awareness is an ongoing piece that we're doing in terms of just, when I'm working one-on-one with staff, we do trying to promote it and taking opportunities to let other people know that it is available. So in terms of some of the challenges that I've encountered along the way, so one is a lack of awareness, and I'd say this is more so in the beginning of the launch of this wiki rather than where I'm at right now. So like I mentioned, we're still doing that ongoing one-on-one promotion. And to address this, we've also, our librarian has been promoting it when she's doing her workshops, and we get a lot of students that come through our organization. I think there's approximately 120 nursing students every year, so we try to do orientation sessions for them where we talk about how do they collect research evidence. So we use the wiki as kind of like a main platform for all the resources and kind of direct them to it. And then I think I talked a bit about the email notification system was ready. So really trying to encourage staff to use that feature on the wiki so that they could see how useful it is. Another challenge is lack of buy-in. So this is an integral part because I really need that buy-in from the potential contributors. So the more people buy into the platform, the more traffic it would generate. So some of the activities that I have used to address this challenge is, presenting the wiki to the management, and we've used it as a platform for our resources for our knowledge broker team. So if there's any type of evidence-informed generation resource or anything like that from that team, we do put it on the wiki. And then the last activity is really just to kind of continue to promote it when people are working one-on-one with Ottawa Public Health staff and just showing them the wiki and what it's used for. And then the last challenges I want to discuss is talking about its usefulness. So I find this is a challenge to measure. We can't measure how useful are people finding it because there's no empirical way of measuring how many people are going to the wiki just because the software itself doesn't count any type of hits, if any hits to a specific page or anything like that. So that's a limitation for sure. And then the other thing that's even more challenging is you don't know, people could be viewing it, but you don't know exactly how many people are actually using the completed work or reviews of other people in their daily work. So that's quite challenging, is to measure the usefulness. So in terms of some activities to address this barrier is that we are, as an organization, will be launching a departmental-wide survey about evidence use in your work. And so one of the questions is we'll be asking if people are familiar with the wiki and have they used it. And I think in order to ensure that it's up to date and current, we're always trying to post the most recent information on there and post the most recent, any type of tools and resources as well that people could use. So then I want to talk about some of the successes. So you probably remember this flow chart. So just reflecting back on the process of gathering research evidence, it can take some time and resources. So some of the successes really speaks to building awareness of what others are doing, which can reduce some of the steps within this flow chart. So, you know, practically speaking, if someone viewed the table on that research evidence wiki page and they saw a research question that's similar to what they're, you know, exploring or investigating, they can either work together with this other person through the process and then that would save them time and resources, or they can even, you know, build on that person's work. For example, let's say, you know, if they saw something that was completed a few years ago, but now the topic has come up again, they can just maybe ask the one healthcare practitioner if they can just take their search protocol and maybe just update it with a more recent year in their inclusion criteria. And then in terms of saving time and resources, because the wiki houses all the tools and resources, a staff member can just work through the processes on their own more efficiently, as it would provide them a bit with more structure on how to search for research evidence. So an example I have is more recently a consolidation nursing student came to work with us, and one of her main projects was to seek out research evidence on the health effects of edible cannabis products. So what the preceptor just directed her to the wiki, and she was able really to just kind of run with it, and she was able to just engage with the appropriate stakeholders and staff and using the steps and the tools suggested there. So it just really facilitated that process. So some other successes that I wanted to highlight was that there's been some activities where the research wiki has really helped in being central in either launching or instigating. So the wiki has definitely built an awareness of NCCMT's evidence-informed decision-making model. So on the slide, it's really talking about the green bubbles right there. And it's really started a lot of conversations at our organizations around the other domain of the model and the idea of looking at, you know, community preferences and surveillance as evidence. I think we were doing it before, but not necessarily formally labeling it as a source of evidence for when we're making decisions. And it's making us reflect if there's a better way to either, you know, collaborate or gather the information more systematically and collaboratively. And then, so if we move over to the orange bubble, so student orientation, I think I spoke a bit about that. So it's just more just talking about how we get a lot of students to the organization, and they're often tasked with doing some type of reviews. And so it's really incorporating that in terms of part of the orientation process, introducing the research evidence wiki, and it has helped, you know, ensure there's some type of consistent approach and that their work is being shared after they leave the organization as well, because they're often here just for a short time. And another one, so just going down to the light purple bubble. So we've launched a initiative called Resource Recess at Ottawa Public Health, and the research wiki has really been integral in supporting this initiative. So the idea of Resource Recess is really that we're really animating, and I say that in quotation, NCCMT's EIDM model. And each recess, we're taking, you know, each of the domains, so maybe public health resource, and we're showcasing or brainstorming what are the resources available for staff to use when they're seeking out evidence from that domain. So we've used the wiki as kind of like a platform to house all those domains. And then the second part of Resource Recess is really talking to a healthcare, someone within the organization that's had experience working within that domain. And then just lastly, going to the dark purple bubble. So another success is really working with our librarian, building a relationship with her, because we work really closely in developing the content for the wiki. I think it's definitely helped and built a relationship with her. I think we both feel pretty comfortable in consulting each other, and Jane's really been integral in terms of championing and helping our organization really embrace and encourage us to use evidence within our daily practice and in EIDM in general. So in terms of progress and how we're meeting our objectives that I kind of made reference to from the beginning, at the beginning of this presentation, I think we're doing, you can see from here that we're doing very good in terms of you know, fostering knowledge exchange as well as creating a centralized platform. I think where we can keep on working towards is building a consistent approach to doing it. I think when this initiative started, the hope was to kind of standardize the way people collect information for when they're doing the review. I think I've definitely standardized more in terms of the tools and the resources that are used, but in terms of how they're gathering the information, I'm learning that people have different skill levels and knowledge and experience in terms of using research evidence. So I think for now I'd probably move that in terms to more of a long-term goal rather than a short-term goal, as I'm realizing it just because the tools and templates are there, it doesn't necessarily mean it's automatic for everyone to do it, and it just depends where they are at in terms of their learning supports and needs. So the last slide, the second last slide is really talking about next steps. So for me, it's to continue to make sure that we are keeping the resources and the tools updated, getting more buy-in from management. We haven't had any formal presentations or anything like that to the management group. And then continue to work on the evidence-informed decision-making, the wiki homepage, and then setting up some type of departmental rollout. There you go. And now the last slide. So the last slide is really I want to talk about some of the lessons learned and recommendations for other people if this is something that you're interested in doing. I want to share some of my learnings. So I think initially when this project was set out, one of the reasons that the wiki platform was chosen was that I was hoping that, you know, there doesn't need to be an administrator and that people will just go on and post. But I think now that it's been a year into the project, I've noticed that I think it's just one extra step for people to do. You know, they usually finish the review, they've gotten what they want, and it's been challenging in terms of trying to get them to do that one extra step and just to post it. So what I've been getting is really having people sending it to me and then I'm posting it. So I think for me right now, I'm fine with that because I still feel like it's a win in terms of their wanting to share what they've learned. So, you know, that maybe becomes a long-term is not having an administrator. But however, I would still pick the wiki platform as there are still advantages of using that as opposed to having everything on a shared drive. And I did talk about that already. And then I think the idea in terms of consistency versus encouragement, and I talked a bit about this in the last slide. And I think one of the initial short-term objectives was to have a more standardized approach for synthesizing data. And I think now that I think that's more of a long-term objective. People are coming to me and letting me know that they're conducting reviews. I think that's successful for me where we are in terms of this project. Another lesson learned is really ensuring that you have a clear parameter of what is to be posted on the wiki. I think initially when this was launched, I was getting requests of people saying, oh, can you put this on the wiki? And it turned out to be like a gray literature article or report from another organization. So we wanted to make it clear that it isn't a repository for gray literature, even though it might be useful, that everything that was posted should be kind of produced in-house, and it was by an internal staff member. And the last recommendation I have is really kind of applies to everything in terms of continuous quality improvement in general. I think at the beginning of this initiative, when I was approaching people to ask them if I can post their completed reviews, you know, I would get some kind of like, oh, it's not very good, not quite ready yet. So I think people definitely had some reservations, and they felt like they were being critiqued for the quality of their work once it was up. So it's kind of always keeping in mind that the primary goal is really to for knowledge sharing and the benefits of others, and that it's not there to critique their work. And I think this will come as we continue to build a continuous quality improvement culture within our organization and providing staff with opportunities for them to learn from their work as well as other people's work as well. So that's kind of all I had to say, but I welcome any, you know, suggestions or recommendations if you have for me if you've implemented something similar within your organization as well.
That's great. Thank you so much to Victoria. I think that was a really very useful approach to what I think is often a common problem in public health is being able to share the information and not just get sucked into your little bubble and being able to coordinate what's going on across an organization. We are opening it up for questions now to Victoria, and we'll open it up to questions for all presenters as well soon. We do have one question already for Victoria. It says, congratulations, great idea. Do you have a quality assurance process? For example, does anybody appraise the quality of the reviews before they are posted?
Perfect. Yeah, so I think that's what, I don't know if that came across very clear in my presentation, but I was kind of trying to speak to that when I was kind of mentioning the section about consistency of approaches. So that's something that I've definitely noticed. And I think for me that maybe of a long-term goal of something to implement, because it's still fairly new. I think being gentle in terms of just kind of, and we want to be encouraging, right? So I didn't want to kind of be critical of some of the work, but I definitely recognize that that's definitely a challenge that we have, and it's something to consider for the future.
That's great. I guess there's a balance between trying to get people confident enough to share and also making sure that things are of good quality when they do get posted. So.
Exactly, and even just to do it too, right?
Yeah. Good. I had a question as well. When you first came up with this project, how did you present it to, for example, to your management to get the resources and the time to be able to do this?
So I'm in a very, I don't know, I have a lot of autonomy in my role, because my role is primarily, you know, one of the main responsibilities is really trying to do that consultation piece and trying to help staff to you know, build their capacity to using research evidence. So I definitely don't think it was a challenge. It was just, oh, I have this idea, what do you think? And she was like, yeah, sure, sounds great.
That's great.
So it's great to have that luxury. I know not everyone has that.
Yeah. Would you have any tips if somebody were to try and present this to their management to get buy-in for this?
I think maybe having that type of framework would be a good a starting point. I think that's where my presentation, like initially, it was really just that one page with a table, and that's all it was. And then I kind of got thinking, well, not everyone can contribute if they don't know how to seek out, and that's how it kind of developed to the other pages and how it got a bit bigger. So I would suggest to kind of have a bit of a more structure and framework.
No, that's great. Great. And a couple of comments here. It would be so great to see this shared across other regions so that the same research isn't being done in multiple places. Great initiative. And I think this is a challenge that we see oftentimes in public health, especially in places like Ontario, where we have so many different public health units that are probably reviewing very similar things. And it can be shared, and it'd be great to be able to share a bit more widely, even between organizations as well as within. So that's great. Another comment, great example. Thank you for sharing Lots of great learnings. Thanks for a great presentation. What you have learned will be useful to others, and that's really what we're trying to do here with this webinar series, is try and make sure that anybody coming at any of these types of problems can maybe learn from what has already been done and maybe save some of the mistakes or some of the lessons learned is benefit from that as well. So we will open it up to general questions now about any of the projects or EIDM initiatives in general. I will move on just a little bit with a couple of closing slides, and we'll see if any questions come in during that time. So we would like to encourage everybody to check out the EIDM Casebook that is posted online at the NCCMT's website, if you haven't already checked that out. We'd also like to hear from you, anybody in the audience, if you have a success story that you think might be useful for others working in the field. We'd really like to have more of a community of sharing, and we'd be very, very happy to hear about any other success stories or even not so success stories that you might have or lessons learned. And if you do have one of those not so successful stories, or if you have any issues, please feel free to email us at the NCCMT. We offer knowledge broker consultations, and we're very, very happy to get back to you. We usually get back to you within 24 business hours, and we can connect you with knowledge brokers and senior staff who have experience with these types of things. We've worked with many organizations in the past, and we're very happy to share what we've learned and what we've learned works and what doesn't work. Your feedback is very, very important to us, especially as this is the first webinar in this series. We're always looking to improve what we're offering, so any feedback that you can provide is hugely appreciated. The survey is only a couple of questions, and the link will be posted in the chat section, and I'm pretty sure when you close your webinar window that the survey will pop up, so that should come up as well. The next webinar in this series we're very excited for will be on October the 19th, which is Thursday at the same time as today. We're featuring another 2 stories. The second one that's listed there is from the Casebook, and it's a story about how a group at Hamilton Public Health in Ontario established a community of practice to help build capacity for evidence-informed decision-making at their public health unit. And the other story is actually one, it's not actually featured in the Casebook, but it's somebody that I came across with at a conference this year. And it's an example of how they used non-research evidence, so they used local data as a source of evidence in order to improve clinical services. So it's a good example of how sometimes, research evidence isn't always everything when it comes to decision making. So an example of how you can use local data to inform practice. And that'll be on October the 19th, and the link is posted in the chat section. You can also find this at our webinars page on the NCCMT website. We do host a number of other webinar series as well. For example, the Spotlight series features methods and tools in the registry presented by the author of the method and tool as well as by a user. So they present a user story and their experience in using the resources with some lessons learned as well there. The topic-specific series features resources that can support evidence-informed decision-making in a specific public health field. So this is something that has been useful in the past for topics like healthy weights or mental health, or for different audiences like public health inspectors or students. And the Online Journal Club is a small group format webinar that gives you a chance to practice your critical appraisal skills in a small group with experts and with your peers. And if you want some more information on these series and to sign up for upcoming sessions, you can check out the website. The link is posted in the chat section. So going back to, I think we did have one more comment come in, and I think this is related to Victoria's project, saying that I think that sharing this type of evidence will be very useful with the new public health standards. It would be a time saver as each agency will be conducting the same types of reviews and searches. So this is, I think, referring to the new Ontario public health standards, which will be implemented in January 2018. And if anybody has good suggestions on how to facilitate sharing across the Ontario public health units for this, please email us at NCCMT. We'd love to hear your ideas, because I think this is going to be a hot topic coming up in the next couple of months. So I want to thank,
I don't know if this was these questions are posted privately, so I can just read the question. I think.
Oh, okay, sure.
and I won't read who it's from, so just to keep the confidentiality. So one of the questions that came up was, how have you been evaluating efficacy or uptake of the strategy? So that was one of the challenges that I put up in the presentation. So it's definitely been a challenge of this initiative. It's been hard to evaluate the uptake just because the software that we have, which is it's a Tiki Wiki, and it doesn't really allow you to see how many clicks you've got in certain pages, so it's kind of hard to tell. And I think the more important piece is really when people are viewing, how do we know if they're using it? We don't really, so I think that's definitely a challenge. And like I mentioned, we will be conducting a departmental-wide survey, and one of the questions we did put in there was to ask if you've heard of it and have you used it. So that's going to be kind of like a loose measure that we're hoping to evaluate. So another question was, can anyone access the wiki? So yes, anyone within our organization, so Ottawa Public Health, can access the wiki. So that's one of the advantages of using the wiki as opposed to a shared drive. I'm not sure if this is universal in all shared drives, but within Ottawa Public Health, you can put stuff in different folders, and different people have permissions depending where they are within the organization, so that could be challenging. So that's why the wiki platform was chosen, was that everyone has access to it, and your login is the same as your work computer login. So it's accessibility, trying to decrease that barrier of accessibility. And then the last question I have that was posted to me was, do students ever do any reviews and post? So, students often do reviews at Ottawa Public Health. It's an easy task. It's concrete. It's often something that we assign to them. And in terms of posting, the posting is often done by the staff member, their preceptor that they're working with, not necessarily with the student. I'd love it to see the student actually post, but I think maybe they're not confident or for whatever reason. So maybe that's more of long-term.
Great. And I've had one more comment come in privately saying that the Fall Prevention Network in the Southwest has been sharing evidence reviews, project planning templates, etc. And what has worked for them is that they can post them as drafts within a location that only members of the group can access, and that helps people feel more comfortable with sharing. And that's a really good idea to help get people over that initial shyness maybe with sharing their work. So
yeah, great. I think that is one of the barriers as well. Is just people feel shy, or what's going to happen. It becomes more official once they post.
Perfect. Great. Well, thank you so much to everybody who joined us today, as well as our presenters. These are really excellent stories, and we really appreciate you sharing them with us. I want to thank everybody who joined and participated. That did make for a good discussion. And we certainly hope to see you at next month's webinar. Make sure you do that, and we ask that you please complete the survey. So I will hand it back to the presenters in case they have any extra comments before we sign off, but otherwise we'll be signing off just a little bit ahead of time. So thank you.